Good. Thank you.
All right. Good afternoon, everyone. It's really exciting to be here. I feel like, Larry, you're still a consummate social worker. You find placements for malcontents, so I feel like I'm in the right place.
I think that means I'm a malcontent myself.
So it's great to be here. So I'm going to spend about a half an hour talking about my journey of learning about outliers. So they're sometimes called superutilizers. They're called all sorts of pejoratives in the healthcare system. But I've spent much of my career trying to understand this group of clients, patients, and have learned a lot of lessons along the way. So I want to talk a little bit about that. So I'm a family doctor. My name's Jeff Brenner. I currently run a very large mental health and social service agency in New York City called the Jewish Board. It's about a $220 million organization. Most of our funds, 90%, are public funds, and we care for all New Yorkers. So it's about a 150-year-old agency, so it was started by Jewish immigrants. Like Catholic Charities, it still has a religious name, but it at this point cares for all New Yorkers. I'm going to get back to, at the end, talking about what I've learned there, but I want to start back at the very beginning. So I began my career in Camden, New Jersey, not far from here, just across the water. At that time, it was the poorest city in the country, most dangerous city in the country. Lived there and worked there, and I was in a small 3-exam room practice and doing classic family medicine. I trained in Seattle. I was seeing kids, adults, delivering babies at the local hospital. And it was in a mostly Latino neighborhood. And much like many of you have experienced, you find that when you lean into a case, when you spend that extra time in a room, you make that extra phone call, you build the relationship with the extended family, you feel like you can move the needle. You can keep people out of the hospital, you can help them learn how to heal themselves and take better care of themselves. But it felt like all around me, every part of the system was arrayed against that. Certainly the hospital and the hospital structure wouldn't translate for people. They had no idea. They would literally go into the hospital and leave, have major procedures done to them, and have no idea what happened. That was sort of a routine. If they weren't English speaking, they would literally go through the whole encounter with no one translating, with no idea what happened at all. Have people going in and out of the emergency room, and I would routinely refer people to mental health, to social services, to addiction treatment, and they get put on waiting lists. They call and try and get in, and they can't get in. When they do finally get in, the services are terrible. So it just sort of like every which way you look, you feel like the system is arrayed against you. And Camden's an extreme place. I mean, I think even in a general primary care office in a middle class or upper class area, you feel like the system's not really arrayed to help you. You know, it's sort of compounded by the level of poverty. And then on top of that, you get these huge forms from the insurance company, the care coordinators at the insurance company wanting you to fill out all this information. And then sometimes I'd like track them down. I'd be like, boy, I got a whopper for you. Like, let me tell you about Mrs. Rodriguez. She's my hardest client. You guys are going to help me. And, you know, they were useless. They had no idea what they were doing, and they weren't really set up to help you at all. So that's the sort of the baseline. And then it's fortunate to, somewhere in this, get through a summer student project and a whole evolution of work, all the claims data, the hospital claims data in the city, and my own patients were in there, and I could literally track them through the claims data, and I had no idea how much hospitals made. I mean, it's not like I just rolled out of bed yesterday. I had some sense that they got paid a lot of money for what they did, but I had no idea the disproportionality between what my part of the system was being paid and what all the other parts of the system. And then you could literally see folks going back, you know, 100 times, 50 times for stupid reasons. So that really galvanized me. And at the same time, the insurers switched me from capitation back to fee-for-service, and like my practice was unraveling. Like I'd gotten really good at capitation. I couldn't make $19 to $25 visits in fee-for-service work. So that was a huge kind of learning moment about how little the system cares about what we do, how poorly it's arrayed to support not only what we need, but what the clients need, what our patients need. and also how much money is flowing through the system. So that was kind of a galvanizing moment. So through this, I ended up creating a nonprofit that built really a seamless care coordination model. We started an HIE in Camden. We had real-time data flows. Every day we woke up knowing who was admitted, why they were admitted, how many times they had been back in the last couple of years for all 3 local hospitals. So that's kind of a big deal. I mean, that was ahead of its time. Yeah. And all our staff had badges, and we could go in and out of every hospital seamlessly. And we could go right to the bedside and enroll a person saying, Mrs. Rodriguez, you've been here to Cooper 5 times, Lourdes, Virtua 20 times. Seems like you're struggling. What can we do for you? Took a lot to get those relationships, get those legal agreements, get those badges, get that IT access. We could log in to all of the EHRs of all the hospitals as well. So, if you turn the clock way, way, way back, I was like, this system is so disorganized. If we just got it organized, then care would be better. And that's the hypothesis, right? So then I worked really hard year after year after year after year after year, raising money, building a nonprofit, getting the legal agreements, getting the HIE in place, building these teams, and then testing it with an RCT, and it didn't work. It didn't lower healthcare costs. Now, running an RCT for this kind of model is not done very often because it is so much work. You go into the hospital room, say, hi, Mrs. Rodriguez, we're from the Camden Coalition, we think we can help you, here are the services we provide, seems like you're having a hard time, and we'd like to enroll you in a trial, and you're going to get randomized either to this intensive model where we do all this care and follow-up, or to just default care. And she's like, who are you? And why are you in my room? And what are you trying to get me to sign? And you hire these amazing people who do all this outreach work, and they talk to people into enrolling in this randomized controlled trial. And you can see why no one does these things. They're a lot of work, and you're also pretty exposed, right? Because you're like, I know this works. I've spent my life and all my energy building this, and you may find out that you were wrong. So we kept this thing really simple. Our teams wanted to add in more and more and more variables to study, and I kept saying, I just want to know, does it reduce utilization, and does it reduce costs? Like, let's not lard this thing up with too many variables and too much complexity. So speed along 3.5, 4 years later, and it didn't. So, I think this is a landmark study in the world of care coordination, care management, because all the claims that all the insurers make, all of these private companies make, that their whole person fancy model saves money, is probably just all bullshit. And they've been riding that to the private equity market, the stock market, the marketing materials of all the insurers, because if this highly intensive, extremely well-trained, multidisciplinary team operating in real time, going to the bedside, following people out, going to all of their primary care visits, to their social services, doing all of this other stuff, if that doesn't work, calling people once or twice a month on the phone surely isn't working. And sure enough, there have been a few studies that have not shown any impact. The reason why we thought these things had impact is people look at pre-post data, and you can't use pre-post data to look at this stuff. So the question is, why didn't it work? About halfway through, we have real-time HIE data. It's a randomized trial. You don't have statistical significance, but you can follow the 2 groups. And we could see that the 2 groups, the intervention and the control group, we weren't making any progress. And then you pull the data apart and say, like, well, why are people going back? And then I'm getting these terrible stories from my frontline staff. And all the primary care providers in the city were my colleagues. I knew them really well. It's a very small city. You wouldn't believe what our colleagues say to outlier patients. They say the most awful, pejorative things when the doors close. The nicest person in the world gets really embarrassed and frustrated when their own patient keeps going back to the hospital and emergency room, or keeps getting another toe cut off, or keeps stroking, or keeps having their sugars go out of whack. We get a little frightened. We feel exposed. We think like all the colleagues at the hospital must think I'm an idiot because you just keep getting sicker and sicker. So number one, our colleagues don't understand these clients and don't know how to take care of them. The specialists are even worse. They say the craziest to our patients. I mean, you wouldn't believe the stuff that we saw. And then you send them over to social services, and it's even worse. So the other thing we learned is these folks had profound early life trauma. They had had physical abuse and sexual abuse at very, very, very high rates. And it turns out the science has caught up with us. And if you've had severe physical and sexual abuse, toxic trauma as a child, your brain and your body are permanently changed. You age quicker than the rest of us. You'll die 25 years before the rest of the population. You will have much higher rates of addiction. You'll have much higher rates of maladaptive social behaviors. You'll have a hard time forming stable relationships, stable friendships, stable family, stable marriage. And you're going to have much higher rates of chronic illness. If you have chronic illness, they'll be poorly controlled. The statistical power of having a significant set of adverse childhood experiences on your long-term health are profound. It's the highest risk factor of almost any risk factor that we know. So it became very, very clear to us that the people that we were working with, the outliers, had very significant early life trauma, that we, the healthcare system, had no idea what we were doing with them, that the primary care system didn't know how to work with them, the specialty care system didn't know how to work with them, the hospital sure didn't know how to work with them, and these are folks that we used to call the difficult patient. I mean, wasn't that horrible literature? I mean, that was the nomenclature. There were articles after articles in primary care in the family medicine literature. I remember whole lectures about how to take care of the difficult patient. The difficult patient had physical and sexual abuse as a child, and they don't form trusting relationships, and they overreact and underreact to stimulus, and their reactions make total sense when you understand what's happened to them. We didn't understand that stuff. We hadn't been trained in it. Meanwhile, the behavioral health system and the addiction system are slowly beginning to understand those clients. The healthcare system is lagging really far behind. The other problems that we uncovered is that the social service side of all of this is in complete disarray. I had many of the leaders in Camden of social service agencies, of housing, mental health, addiction treatment, on my board. They were friends and colleagues. They talk the talk. But when clients actually go to their front door, bang on the door, call for an appointment and get in, the care was awful. It was just profoundly dysfunctional. So I want to talk about the sort of next step in this sort of exploration of trying to figure this topic out. We began to realize it wasn't working. And the other thing that was holding us back was there's not just overutilization. I actually think that there is underutilization as well. So lots of people with early life trauma could either end up overutilizing the system profoundly, or they could end up with profound underuse of the system. You know, this is sort of your typical guy who just checks out and just has heart attack and stroke, won't take their meds and stays at home. So, you know, in some ways we were focusing on just one half of the problem. There's this whole other interesting part of the problem that's underutilization as well. The other part that we were missing was that all of these different things are risk factors that contribute to a maladaptive set of behaviors, that contribute to a mismatch between where in the system you belong, what the system can do for you, and what part of the system you need to be engaging with. Either overutilization in the wrong part of the system or underutilization in the wrong part of the system. So you've heard the term social determinants, and I think it's the wrong word. I would use risk factor. And if you use the same way that you think about cardiac risk factors, I think we have social risk factors, we have life history risk factors, we have genetic risk factors, we have all of these different risk factors. The term social determinants came from demographers in Great Britain back in the 30s, 40s, and 50s. And if you look at a map in a large region and you map out poor health and poverty, they perfectly overlay with one another. So as a demographer, if you're looking at a map, you can say that poverty is deterministic for poor health outcomes. The problem is when you get down to individuals, it's not a deterministic variable. There are plenty of people who grow up poor who are in great health. Plenty of people who grow up wealthy who are in poor health. So these are risk factors at the individual level. They're determinants at a population level. So, to Mrs. Jones, we're going to screen you for social determinants is a stupid statement. Mrs. Jones, we're going to screen you for social risk factors. That makes sense. So we're misusing the term. So what I would argue is that the biggest challenge for dealing with outliers in healthcare of extreme overutilizers and extreme underutilizers is these are heterogeneity. These are heterogeneous outcomes. There are many, many, many different things that could drive you to being an overutilizer or underutilizer. So it was incredibly simplistic of me and our organization to say, like, healthcare is disorganized. We just need to run out there and organize it, and that'll make a lot of improvements. It was true that healthcare is disorganized, but that was really just a symptom of much more profound underlying risk factors. And these individuals have, tremendous heterogeneity of different risk factors that have driven this outlier utilization. So, for example, there are, unfortunately, a fair number of Americans that have sickle cell. If you look at claims data, there are overrepresented in outliers of claims data people with sickle cell who are going back for lots of different reasons. But there are many people with sickle cell who aren't overutilizers. So there's clearly some other variables going on here. So what you'll find often is the folks out here have also severe poverty, often mental health issues, they may have family stressors, they may have early life trauma as well, all these compounding things added to an underlying genetic disorder which results in them being an outlier. So let me bring the story forward. So I think we began to realize that it wasn't the coordination is just the postal system. It gets you somewhere. If it gets you to shitty care, then actually the postal system could be causing harm because care coordination is going to get you more unnecessary care more quickly. That's a pretty frightening thing. I mean, we actually stood back and said, holy shit, maybe these people are better off in the shit mess we found them rather than speeding them up to get more testing, more procedures, and more medication. I mean, that was a pretty awful moment. The other thing we started to realize is that for outliers, for people with all these risk factors, there was a growing body of evidence-based treatments that were incredibly effective. And there was this big voltage gap of those treatments not getting to people. So a great example was Suboxone. Suboxone is treatment for people with opiate use disorder. And if you give someone Suboxone, you drop their overdose death rate in half. There's almost nothing else we can do in healthcare that drops the death rate in half. That's miraculous. Like, you have to go back to AZT or some of these new cancer treatments to see that kind of drop. But huge numbers of people aren't getting access to that. There is so much stigma in the healthcare system and stigma in Camden at that moment that people aren't getting access to it. So it's a really good example where you've got this outlier group, you've got this important treatment, we're not following the evidence base, and that evidence base would make a big difference for those outliers. So even where we have treatments for outliers, we're often not following the evidence base for what good care of that outlier group would look like. And certainly in Camden, we knew we didn't have access. Another good example is Housing First. It's a model in which you take someone right off the street and you move them into their apartment, no questions asked. It's low barrier entry. And lo and behold, not everyone does well, but a lot of people do really well. Folks that you would walk by on the street mumbling to themselves, who you would just write off and say, this person could never live on their own. Now, you're going to visit their apartment, and it's, like, you're not walking into IKEA here. These are not, living lifestyle that you might imagine for yourself or your family, but they're not on the street. They're resting. Their voices actually begin to get less and less because they're not so stressed out. They're sleeping at night, and their addictions will sometimes get better without any treatment just because they're not so stressed out. So Housing First, totally unavailable in Camden. In order to get into housing, you have to prove you're a worthy poor person. and you have to jump through all of these different hoops. And then if you're good and you never break the rules, you never fall off the wagon, you never have a relapse, you never yell at anyone, then you might finally get a housing unit. If at any point in that you do any of those things, you go all the way back to the beginning and start over. So once again, that's another example of an evidence-based model that's not widely available, that would make a profound difference for different outlier groups that we didn't have access to in Camden. So I could go on and on. Another good example is IM antipsychotics. So we take people who have had a ton of early life trauma and have active psychoses. We admit them for 2 weeks. We rapidly street them, get them back out, put them in a shelter often, give them a bottle of antipsychotics they've got to take twice a day that have side effects and expect them to remember that. And then we wonder why they're still mumbling out on the streets. IM antipsychotics have come along, and a lot of places, you would think the hospital would give them an IM antipsychotic on the way out the door, but they don't do that. So once again, another example of an evidence-based treatment not being widely used. So my next step in this journey was I was invited by Cooper, which in Camden is the major academic center, to come and run their specialty office, which is 18 different specialties, all the medical and surgical specialties, and all of the residents and fellows. This is the biggest chaotic mess you've ever seen, right? And it's not just Cooper, it's like any place where you put that many residents, fellows, and specialties, all treating Medicaid patients in the poorest city in the country. I mean, it's just gonna be chaos. And sure enough, it was the most chaotic thing I've ever seen. I had specialists making $1 million a year, and we're back charged for every hour that they worked in our business unit. And I'm like, you have to show up. You have to get busy. We need to overbook you because you're making $1 million. You're making $1 million a year. That's like $1,000 an hour. But it was an incredibly chaotic business unit. I actually had a lot of colleagues and friends that were specialists and working there. And what was so amazing is that they were the warmest, kindest, most loving people if you meet them. But then I got to read all the patient comments, right? You have these cool systems that get patient feedback. And it's feedback at the individual level, plus they'll actually give you the exact text of what the patient said about. And once again, you wouldn't believe what outlier clients say that our colleagues say to them behind closed doors. And just saw voltage drop after voltage drop. The only successful thing I did there was to start an addiction treatment program where for the first time in Camden, very large numbers of people could get access to Suboxone in the emergency room while they were in the middle of withdrawing. So we got the entire emergency room X-waivered. We got all the OB docs X-waivered. And that was the first time in my entire time in Camden where I actually felt like for this outlier group of people, and not the whole outlier group, but a subset of outliers. Opiate addicted people who come repeatedly to the emergency room at Cooper in an overdose situation. And it turns out that when you are withdrawing, it's the perfect moment to start Suboxone. The ER is the best place to start Suboxone, and it drops your death rate by 50%. So here's the evidence-based treatment that took years and years and years and years for me to get to the point where I could get that evidence-based treatment done at scale, at the point of care, when it mattered, for one subset of outliers, where we finally moved the needle. The other place we moved the needle is we started to do housing first. We raised a whole bunch of money, rented apartments, and started to put people in them. And I can't tell you, that is the most profound moment in my career, is visiting folks that you've moved in and then seeing them over the next couple of months. And what a just profound change, seeing them re-engage with their friends, their family, with themselves, and have productive, generative lives. Folks that I'd literally walked by, and Camden's small enough. You see people at the transit center, you walk by folks now beginning to put their lives back together. But once again, that's a subset of a subset of a subset of outliers with a hard to do evidence-based treatment that makes a big difference when you're able to get that when it's necessary. So I think all this illustrates that I started out with a very unsophisticated view of the problem. Over time, gained a more and more sophisticated view of how deep, complex, and heterogeneous the problem is. And it's a problem of matching evidence-based treatment to many, many, many different subgroups, delivering that evidence-based treatment in the right way, in the right form, executed well. And it's going to take us a long time to tackle this outlier problem. So I want to touch on two more points in the journey. I went to work at United Healthcare, and I was on the senior team of the Medicaid arm. And they're the fourth or fifth largest company in the country, and I was, 4 steps down from the top. And I was brought there to help them develop a social determinants agenda. And they actually wanted to productize it, so they wanted to create social determinants products. So, in their lingo, care coordination is a product, and we were going to add a new vertical, another product. And they actually had created all these different funny verticals. Like they'd actually created a debit card they were sending out to United Healthcare patients called My Money, and they would load an incentive up if you got your kids vaccinated. So that was going to be a vertical to cure poverty. There was another vertical around transportation, there was a vertical around housing, and a vertical around a whole bunch of things. I closed all the verticals. The only vertical I kept going was the housing, because in my mind, that's the only vertical that I could ever generate a return on investment in the quarter by quarter, half year by half year, month by month, P&L, profit and loss statement in a United business. I thought, I'm toast on all this other stuff. I got to quit doing this because I'm never going to be able to show any kind of financial benefit to the company. But the cool thing about housing is you get the right person in the right housing unit, you can show a financial outcome literally within a few months. So, but it's only if you pick the right people. So we began to put people with more than $50,000 a year in spending. We really wanted the folks that were doing $100,000 a year, where it was due to repeated ER and hospital use. We put them into a new apartment with wraparound services, and we were able to generate an ROI, and they blessed us to grow it. So we grew it up to 22 communities where we contracted external vendors for the service. And then COVID came, and I'm in meetings, and there was 2 things I realized. One is that you're either in the strategy bucket at a company that large, or you're in the marketing budget. And I started to realize that I wasn't in the strategy bucket, that I was in the marketing budget. Because they really only wanted to grow this thing to 10 or 20 units per market, just so they could put it in their RFP when they were applying for a new state or a new market or renewing their RFP. So it was really all a marketing gimmick. It was not a strategic thing. So that was one piece. The other is when COVID happened, the insurers made extraordinary profits, and they sat on all of the money and they didn't do shit. And I was in the rooms, I can tell you, we didn't do a thing. And we had an opportunity to do a lot of really meaningful stuff, and we didn't. And I'd say in the third bucket is, there's all this rhetoric that these are healthcare companies. They are not healthcare companies. They are insurance companies. Insurance companies are in the job of saying no, and you need someone to say no. They're in the job of processing claims. You need someone to process claims. They're not going to fix the American healthcare system. They have no interest in value-based payment. We were paying this much attention to value-based payment. We wanted it just to go away. And the only thing we wanted to do is dip our hand in this stream of money and grab as many dollars going through as we could. And I can give you hundreds and hundreds and hundreds of examples of that. Now, is that United's fault? Is that Anthem's fault? Is that Aetna's fault? No, it's our fault. And I don't mean doctors' fault, I mean the public's fault. These are all highly regulated insurance companies. State by state, there's an incredible regulatory infrastructure. We could bring them to their knees tomorrow. They need to go back to being boring claims processors. They actually made a huge impact on healthcare spending, on bed day management, formularies, on processing claims properly. It's actually really hard to do those things. They need to go back to doing that. They need to be put in a little box, and that's it. We don't need to privatize that. We don't need to, take all their, go to some huge public system. We don't need single payer. We just need to put them back in their box and keep them in their box. That's it. Which is a boring answer. It's not an exciting, glamorous answer. All right, so one more point. Got about 5 minutes, Larry? Am I on top? 3 minutes, okay. So in my current job right now, I really got to the point where I'm like, the real impediment to all of this is amazing mental health, addiction, foster care. A lot of outliers, high utilizers, are former foster kids. Domestic violence services, housing services, IDD. It's this whole other part of the healthcare social service economy that I really had no idea about. I didn't really know a lot about. But every time I touched it, I was profoundly bowled over and impressed. Not by how well they delivered services, but by all the interesting innovation going on and all the idealism over in the sector. So I jumped at the chance to be the CEO and run one of the largest mental health social service agencies in New York. It's a $220 million organization in the world of mental health. It's a very large organization. I've been there 3 years now, and it is the most interesting experience of my career. It's a little bit like going in a time machine, back to the beginning of your career in healthcare, and then go back a little bit further, back when there were paper charts, paper scheduling, maybe even go back a little bit further, back when there was Susie on the front desk did a good job and got promoted up to being the office manager, and then got promoted up to being director of primary care at a hospital, got promoted up to being a high-level executive at a hospital with no additional training other than being good when they were at the front desk years before in their career. Hospitals were very unprofessional, unsophisticated organizations that were all paper. That's what social services, mental health, and addiction in America is like. Now, I'm casting a very broad brush, but I think it's fair to say that for a whole variety of reasons, underpayment, chronic underpayment, that social services is way behind healthcare. It never had to err as human, right? That was an epochal moment where process improvement, project management, all these things came into healthcare. Never had that. It didn't have meaningful use, all this huge investment in electronic health records. It has operated on fumes for years and years. So that's the problem. Here's the opportunity. In the last 20 years, there has been the application of randomized controlled trials to the field of mental health and addiction and foster care in a way that is absolutely profound. I have, because we're so old, I have archives. I read back to the CEO back in the 50s, and he was a pretty famous provider in the child mental health space. And he writes in there that, to be honest with you, we pretty much are making this all up. We don't know what works, and we don't know what doesn't work. And one day we'll apply the scientific method to child mental health. So the good news is that in the last 20, 30 years, there's been an amazing application of randomized controlled trials to create incredible innovations. And none of those are getting out to the public. So cognitive behavioral therapy, dialectical behavioral therapy, parent-child psychotherapy, a whole world of prevention foster care programs where evidence-based programs have shown if you go into a family's home that has been had an abuse and neglect allegation, that you can actually keep that family together, not take those kids away, and rebuild that family structure. All these incredible innovations are not scaling. And they're not scaling because there are no residencies. We don't have a trained workforce. The workforce is fragmented. The regulatory structure is chaotic. The payment structure is chaotic. All these different things. So all this is to say, I've been on a long journey to figure out what makes outliers, what can we do about outliers. And I don't need your social determinants referrals. I don't need your closed loop referrals. I have plenty of clients. I have more clients than I know what to do with. And the big problem that social service agencies are having is not the lack of closed loop referrals and social determinant screening. We've got much bigger problems. And it's going to take a few more careers and a few more generations to really tackle all this stuff and get it figured out. My hope is that primary care is a natural ally of mental health, social services, and addiction. And that's probably where we're going to make the most impact, is probably peeling off primary care for outliers over into that side of the system. It really doesn't belong as the feeder for specialties over on the healthcare side. I think the data for ACOs has shown us that either independent primary care, but certainly not hospital-based primary care, is the long-term fix. So let me stop there, and yeah, thank you, Larry.
Thank you, Jim.